fatigued out or depressed. Or he could be taking antidepressants. Fun fact, in the US, 12% of men above the age of 50 are on antidepressants. So are women. The interesting thing about this is there's actually a published paper that shows if you correct testosterone, more than 70% of these men don't require antidepressants. And the nice thing about antidepressants, they have this little warning that says, risk of committing suicide. Okay? And I'm not kidding, you can look it up. All right? And the same applies for women. Depression is major after 50. Okay? All right, so I divided up into 2, right? So you have your symptoms, what I mentioned just now, and I will show you the paper for this. There are 2 or 3 papers on metabolic system. Now, why I like metabolic system? It is measurable, and it includes waist circumference. For those of you who have that thing that measures, sorry, skipping my mind, what's that thing that measures how much fat muscle you have? Sorry? In body, right. So you can measure lean muscle mass. You can measure fat mass. BMI will not be accurate in patients on testosterone therapy because you'll see the weight stagnant, but you see waist circumference go down, muscle mass go up. HbA1c, insulin levels. Sorry, how many of you all are clear on measuring insulin for diabetics? Okay, so what I normally do is I measure fasting sugar and I measure the insulin at the same time to see the insulin response, and I do a postprandial and measure both. These are for my testosterone replacement patient. I'm not an endocrinologist. So HbA1c, fasting sugar, postprandial sugar, triglyceride, LDL, all the simple ones, HDL, what am I missing? Waist size, muscle mass, fat mass. These are your measurable components. So when I treat the patients, I've listed down their symptomatic diagnosis, and I list down the metabolic parameters. Because sometimes you're going to get patients who come and tell you, because you don't see symptom relief overnight. It takes time, and sometimes the patients may not realize. If you look back at the old symptoms and ask them to compare, they'll get it. But metabolic parameters are easy to measure. Okay? All right. Are we good up to here? Okay. Now we come to the hard, boring stuff, the papers. Okay, this is basically what I said earlier. I've listed down the metabolic, the psychological, the sexual, and the physical. Right? This table is easy, and I have a questionnaire that I put this into, which I didn't give you all, but anyway, I just tick it off. And mentally, I have a score. So if someone comes and says, fatigue, low energy, I mentally assign them my own personal score. This is not science-based. It's just a way for me to keep track of what their symptoms are. And it's something I agree with the patients. That means they come and tell me, okay, my fatigue is this bad. So I assign a score, say 3 out of 5. Okay? And it's something I agree with the patient. That means we both agree that 5 means you're good, up, perky, you get up, you run out of bed, do exercise. 1 is, I crawl out of bed and I want to crawl back in. Okay? So what's 3? I agree this with the patient. I see them back usually I see them back at 1 month to make sure they don't have problems. Look at the score again at 6 months. But this is a score that is very subjective. If you want to do it, do it. I do it for my patients. It's just something for me to keep track. Metabolic parameters, easy lah, that's your blood test. And that is the most objective thing you're going to have. And the thing you want to have in your case notes, in case anyone ever asks you why you did what you did. Right? Simple. Okay, do I have to go through this again one by one? No, right? Okay. Sorry, my swara also dying already. I don't know how the previous speakers did long talks. I've only done like 15 minutes, I'm only dying. Okay. All right. So by the way, I didn't create that. I stole it from this paper. This is a 2006. So just to tell you how long we've been doing testosterone papers. This is 2004 and 2006 paper, and it's here and you can look it up. Do we provide hyperlinks? No. Okay, so you have to physically type it in. And basically, what they did was they looked at testosterone levels, correlation to metabolic symptoms. Okay, metabolic indicators and symptoms, right? And you can see this. I mean, I'm not sure how much more clear you want. Lower the testosterone, the more crappy you feel. Okay? So if anybody wants to correlate, or if you want to look it up, those two papers are really good. They are the ones I use as a basis on why I put up that earlier list of symptoms. So if you look at this, so this is what you would call evidence-based medicine. These are the symptoms of low testosterone. Now, unfortunately, human beings are not robots. So there'll be a lot of people in there, and a lot of your patients with low testosterone have other endocrine disorders. Low thyroid. So last time we say, you measure TSH, you say TSH 0.7 to 5 is normal, right? If you dig deeper, patients with a TSH of 1.5 to 2.5 actually do better than everybody else. You don't want them to be hyperthyroid, but you want, if you look at patients symptomatic 1.5 to 2.5 TSH, I know it's off topic, their symptoms together at testosterone, they do pretty well. So I tend to add a little bit, adjust the TSH levels. But what I'm trying to say is, these symptoms are not exclusive to testosterone. This paper, they screened out everything else. That means they screened out thyroid, they screened out chronic stress, they screened out hypercortisol. Okay? And they came up with that list of metabolic syndrome. But in real life, in Malaysia, you're not going to get this. This is a research paper. In real life, please God, look at other things. Okay, I've seen one patient, I won't tell you from where, treated for low testosterone. The patient had CCF, he had diastolic dysfunction. Basically, doing diastole, heart doesn't pump, dilated like hell. Of course, it's chronic fatigue, because any little bit of exercise, he's out. Okay? And the more testosterone I pump into him, it's not going to make a difference. A lot of patients have clinical hypothyroid symptoms, biochemically, not so much. But the TSH will be like 4.55, higher end or normal. Okay? So, what I'm trying to tell you is, when you have a patient with one endocrine disorder, don't assume it's one. In Malaysia, from personal experience, I don't have paper for this, a lot of patients have multiple endocrine disorders. Check. Okay, now the really boring, anybody want to sleep? Now it's a good time. Okay. All right, before we come to this, you want my swara dying? Anyone want to ask me? Anything you want to ask me? Yeah, I can't be that good that nobody asks me anything. Come on. Either you all are ignoring what I'm saying, or I really am that good, but okay. Seriously, no questions? Before we get to the really boring stuff? Nothing. Okay, let's go to the really boring stuff. Okay. Actually, I just saw this paper and realized I forgot something. Now, men produce something called dihydroxytestosterone, right? That means testosterone converts to dihydroxytestosterone. Dihydroxytestosterone, both a good guy and a bad guy. It's a good guy because it's 3 to 5 times more potent than testosterone itself, right? And you need 5-alpha reductase to convert testosterone to dihydroxytestosterone, right? Okay. The bad thing about dihydroxytestosterone in men who are sensitive to hair loss, dihydroxytestosterone binds to the hair follicles and you get male pattern balding. Okay? We are good? But remember this, it's also very, very potent. So this paper, so finasteride, I'm sure many of you are familiar with finasteride, right? So finasteride, 1 milligram we use for hair loss, 5 milligram for prostate enlargement or dutasteride. There are 5 ARI inhibitors. So they block the conversion of testosterone to dihydroxytestosterone, right? So I should have mentioned this earlier about, DHT, dihydroxytestosterone. So I skipped my mind until I saw this. All right. So this is a randomized control trial. It's a level 1 paper. Okay. Came out in 2004, just tells you how long ago. So when they initially did it, they divided up patients into 3 groups. One got nothing, one got pure testosterone, and one got testosterone plus finasteride. What they were trying to see was, if we don't give you anything, what happens as you get older? And the men in this group are old. Okay, older than me lah. Okay, 60 to 65 to 70, I think. Okay, I lost track of how old they are. More than 65, correct? More than 65. And they wanted to see, if I don't do anything, how will you age? If I give you pure testosterone, how will it age? If I give you testosterone, but I take away dihydroxytestosterone, what happens to you? Okay, so this was one of the earliest papers, and it's a level 1 evidence paper. So just tell you, 2006, we already had this. How many of you heard of testosterone therapy in 2006? Okay, how many of you started practicing after 2000? Okay, only one person. Most of you look very young, so okay, forget it. Okay. So what they did was, this is the basis of the study, right? Okay, simple, 36 months, men more than 65. So, this is the graph. I try to simplify this graph as much as I can. Okay? Placebo, TRT plus finasteride. So, they wanted to know what was testosterone's effect, what was dihydroxytestosterone's effect. The main thing they looked at was bone density. We'll come to the secondary outcomes later. So, for bone density, it was a testosterone effect. It wasn't a dihydroxytestosterone. Interesting thing, everybody's BMD went up, except the placebo group. That sucked. But whether you're on testosterone plus finasteride, it goes up. Why is this important? And by the way, this applies to women as well. If you have a hip fracture, your mortality is 30% within 2 years. So your chances of dying from osteoporotic fracture is higher than your risk of dying from cancer, or endometrial cancer, or for estrogen or breast cancer. Your chances of dying from bone fractures, let me tell you this again, is higher than anything else. Cardiovascular disease, you pick whatever you want. If you have osteoporotic fractures, you will die, 30% will die within 2 years. And most will be incapacitated. So if I have to pick one single thing that I want to achieve with HRT, sorry, I'm talking about women, but males as well, I don't want osteoporosis. And almost always, osteoporosis goes with muscle mass loss. The alpha-2 fast twitch fibers, okay, I mean, ignore the fast twitch fiber part, but you can't ignore it. Okay, alpha-2 fast twitch fibers are the fibers that stop you from falling. That means when you trip and your reflex put your hands out, that's the alpha-2 fast twitch fiber. Those fibers drop starting from the age of 35, so the levels start going down. Unless you work out, you do gym, you do exercise, or you're on HRT. So what does it mean? Young kids, they get accidents because they drove the car too fast. They use their motorbike too fast. Us, we get fractures because we fall. Testosterone therapy reduces your bone loss, reduces your fracture, and reduces your risk of fall. So if I have to pick one benefit that you're going to see across the board, surprisingly, this would be the one. And we've known this for 20 years, right? And still we don't use it. So anyway, finasteride didn't do anything for it. Important thing, this line. See this? This is a randomized trial. They had no adverse events. So the trial wasn't stopped. It ran its full 36 months. So for those who wonder why I want to give testosterone to men and women, number one reason. Okay. Secondary outcomes. So now from 2006, drug companies have been promoting finasteride and dutasteride, partly based on this study. So what they found was, all guys, I got bad news for you, our prostate will get bigger. Okay? You can't run, our prostate will get bigger. Okay? Now, in the placebo group, prostates got bigger. Testosterone group, it got bigger faster. Sorry. This is not a cancer trial. I'm talking, this is a BPH trial. Benign prostatic hyperplasia, what we normally have urine symptoms. So, placebo, prostate got bigger. Give testosterone, prostate got bigger. So, patients are symptomatic. Testosterone plus finasteride, prostate got smaller. Based on this is why you have all the marketing for finasteride and dutasteride for BPH. Okay, clear? Clear, right? Okay. So as you can see, most of men's health is this thing. Now, interesting thing about PSA. Okay. Remember, these are not cancer patients, right? So this is important for all of you all when you do blood work. In the placebo group, PSA went up very slowly. Testosterone group, it also went up very slowly, but it went up. In the finasteride group, PSA levels drop. This is an artificial drop. It does not change your risk of cancer. That means if you are using PSA and you are giving finasteride, just because you give finasteride, PSA drop does not change the patient's cancer risk. So from a clinical practice guideline, what do? I just double it. So a patient comes with a PSA of 2 and he's on finasteride or dutasteride, I double it to 4. Okay? So this, the key takeaway from this, finasteride affects prostate size and it affects PSA levels. So does testosterone, makes it bigger. So how many of you all now think it's a brilliant idea to give finasteride to patients? No one? One. So you're giving finasteride to patient because you want to shrink the prostate, right? Correct. Okay. Actually, it works. So you get a 30% drop after 6 months, and you get it starts working in 6 months, and by 2 years it shrinks by 30%. Okay. Downside: without good levels of dihydroxytestosterone, our sex drive goes down. So you shrink the prostate, but you drop your sex drive, which is why a lot of urologists don't hand out finasteride, because I'm a guy, I don't want my sex drive to die. Okay. So it kills the sex drive. So finasteride and dutasteride will kill your sex drive. On a plus point, your hair will grow back. Okay. So you get a balance. You get a smaller prostate with nice hair, or you take dutasteride. Now, there is a way to balance it, but you need TRT to do it. But there is a way to balance. So if you give finasteride and dutasteride to your boyfriend or husband, that's going to be very interesting for your boyfriend and husband. Okay? So, this was a landmark paper, and most BPH and testosterone complications were based on this paper. So when you want to explain to patients and you want to say, look, there were no adverse events, the PSA drop was expected, the prostate drop size increase is expected, this is your paper. Okay, key points. Basically what I told you all, right? Prostate size, PSA, okay. Yes. Sorry, getting old, I missed this one. Hematocrit. In the placebo group, a lot of patients actually had, as they got older, they became borderline anemic. They actually had lower hemoglobin. On the testosterone and testosterone finasteride group, hematocrit went up. Now, this is, take it as standard that hematocrit will go up in testosterone replacement. It can be both a positive and negative. I'm hospital-based, right? I treat HIV patients. I treat end-stage renal failure patients. They have low hemoglobin. So for them, testosterone is fantastic. It reverses the sarcopenia, the muscle mass, and reverses the loss of hemoglobin. For your normal average male who's getting overweight, who snores a lot, who's got sleep apnea, who's a smoker, not a great thing. This is not polycythemia. So